ahead. And so I think this idea of anticipatory treatment for known surgical cancer pain is really, really important. And we'd love to hear what you have to say. Thanks for joining.
Great. Andrea, do you mind if I just make a comment too? Just Andrea's been working on this concept since I was a resident. So she and actually has been written papers on it, and also given talks nationally on this concept. So it's really important. I think she has there's a lot of good pearls in here for not only faculty but especially for residents. So everybody try and take notes.
Yeah, well, you're setting me up there, Than. Okay, well, we'll see. So thank you everybody for joining me today. And these are my disclosures, none of which are relevant. And I think the biggest thing I want to pass along is I don't have a magic wand, and I wish that nobody had pain and that everybody did great after surgery, but I don't have a magic wand. So before I lose everybody later to this, that, and the other thing, I wanted to thank some people. I wanted to thank Than and Sharid, and this is a picture on Dr. Benzel's back porch. Several years ago, you'll recognize Wendell in the back with me, and Chris Nickley, Bobby, and his wife Christine, and of course Greg and Dan at my first spine section meeting, the nursing staff at an ANN meeting just last year, and then the residents all the way from Sarah to Clayton, and we enjoy seeing Dr. Dempsey every morning as we start our day to check in on us, make sure we're all doing okay and the patients are. And Clayton is going to be going to Miami to work with Mike Wang in just a couple months, and Mike Wang is very passionate about this subject. So I'm sure you'll hear more about it and Mike's take on it when you get to Miami. And then of course, Dr. Benzel that has given me lots of wonderful opportunities. So this is our path today. I'm going to talk a little bit about what I see as the problems, the solutions, a little bit of history, pain mechanisms, preemptive and multimodal analgesia, the Pain Society guidelines, what we try to do in our hallway, and is this really the end? And hopefully, if you look at this pathway, it'll help you from getting tripped up too much. So what are the problems? Well, historically, pain has been looked at as a fifth vital sign. We used to have signs in our clinic that said you have the right to have zero pain, and if you have any pain at all, it needs to be treated. In the pain clinic, they had the concept that you could not give too many opioids, and people were on more opioids than you can ever imagine. There was a societal expectation that they should have no pain. Patients came to the hospital thinking that also. And so this led eventually to the opioid epidemic that we're in today. People were having overdoses in the hospital, even though they thought that I should be being cared for there. How am I ending up OD'd on narcotics? But they do have painful surgeries. And so this study looked at pain, what people's perceptions were of pain, and 84% were afraid of having pain after surgery. This was just surgery in general. And in 2017, from data that went back to 2011, spinal fusion was the second most common procedure where people had overdoses with opioids in the hospital. The number one was a pneumectomy and lobectomy, and spinal fusion was number 2 for opioid overdose in the hospital setting. So, as we know, opioids are not well tolerated. They can OD in the hospital. There's many side effects that we don't want, like constipation, urinary retention. They're just a wet noodle, don't want to move, don't want to get out of bed. Each patient has a unique response to opioids, and so this requires constant, ongoing, appropriate titration of medications. The right medications have to be ordered, and it's a lot of work on the provider's part as well as the nursing staff's part to make sure that they're getting better and not worse with medications. They have to have a lot of knowledge. I can tell you regarding OD in the hospital that I asked Ellie Brzezinski just yesterday when the last time was we had to use Narcan, and she wasn't sure it had been so long. And my last recollection was actually with a halo placement several years ago. So, however, without adequate pain control, patients are more likely to be immobile and have delirium, as well as be very unhappy, and their families also. Then we can also look at the healthcare quality measures for people who don't have adequate pain, including an increased length of stay, increased costs, satisfaction, and discharging to places other than home. In Chicago, they looked at 500 older adults greater than 65, and for readmissions within 30 days, 14% of those were due to pain, and those people required pain management. So when we think about pain management, whose perspective are we addressing? Are we looking at a patient-centered perspective, which means that it's a report that comes directly from the patient without any sort of amendment or interpretation of the patient's response by a clinician or anyone else? And this is pretty tough because we kind of put our own spin on what people say all the time. The tool that is used for pain measurements is commonly a visual analog scale or a numeric analog scale for pain measurement. Or are we looking at it from the perspective of a nurse or the residents or even the attendings? And we'll talk about the difference between patient-centered and clinician-centered in a little bit here. So what is the solution to these problems? Well, that's a good question. There's a lot of problems, and there's a lot of problems I didn't even talk about. There's a lot of gaps, but it needs to be patient-specific, and how can we get it down to that? What are the answers? So way back in the dark ages, when Shard and Than were residents and Debra Gordon was here, we looked at the comparison of IV PCAs versus multimodal pain therapy. And we're going to talk more about this study in a moment, and this is just a precursor slide of what we're really about today and how I ended up being a believer in multimodal pain therapy. And as you can see, Denise, Greg, Dan, and then Dr. Zadeblik were all on this also. So just a little bit about pain mechanisms. The primary afferent neurons transmit information from the periphery to the dorsal horn. The information is transmitted then via this hypothalamic tract to the second order neurons, to the thalamus and the sensory cortex. Descending inhibitory fibers modulate the afferent input at the dorsal horn. So what peripheral sensitization, so there's peripheral and central sensitization, and this is all the pain pathways, and this sensitization is all really simplified because like Reg Tate always says, I'm a simple person, and so I have to look at this in a simple way. And this is how I see it. Peripheral sensitization is a decrease in the pain threshold and an increase in the responsiveness, an abnormal increase in the responsiveness of the nociceptors. So what happens is with tissue damage and inflammation, there's a release of inflammatory chemicals by the inflammatory chemicals at the site by sensory nerve fibers and inflammatory cells. So some of these can directly activate peripheral nociceptors, and other of the chemicals have a modulating role, leading to enhanced responsiveness of the nerve endings, and meaning a bad enhanced responsiveness. The implications, there's also implicated in this are altered gene expression and post-translational changes. So in this pictorial, you can see that the person has a lesion, and then there's a bradykinin release, acetylcholine, all kinds of other substances such as prostaglandin, serotonin, substance P etc. So the functional changes that happen after injury or inflammation are that some alpha, delta, and C fibers have, just 1 second, I just got to fix one thing, have lowered threshold to firing in response to nociceptive stimuli. Some alpha, delta, and C fibers have enhanced responses, and then adjacent naive alpha, delta, and C fibers expand into the injured area. They actually grow into the injured area, increasing innervation and the sensibility of the injured site. So it senses more at the injured site than it should be. There's recruitment of myelinated low threshold alpha beta fibers under pathologic circumstances conveying painful stimuli. So there's changes in the spinal cord mediated neuronal gene expression, immune cell activation, and modulation of the descending inhibitory pathways, which lead to disinhibition of the pain pathways and secondary hyperalgesia. So what central sensitization is because of the peripheral sensitization creating this constant noise, this constant barrage of information coming in, then there's a persistent exposure of the primary afferent nociceptors to the dorsal horn, and this results in tactile allodynia and secondary hyperalgesia. And pain is generated as a consequence of changes within the central nervous system that lead to alterations in how the person interprets these sensory inputs. So there's neuroplasticity changes that occur and central sensitization. So it helps me to think about it as the spinal windup. You have the peripheral information coming in, this reduction in the thresholds from the surgery itself, barraging the dorsal horn, and then this is this constant, they call it a spinal windup, leading to the hypersensitivity and the responsibility for a decreased pain threshold. So what preemptive analgesia is, and some authors refer to it as preventive analgesia, is protecting the nervous system from the sensitization. So stopping it before it ever starts and can get to the wind-up stage. So pre-treatment that will diminish future pain. So one last way to look at this is there's the tissue injury. There's the activation of the arachidonic acid cascade leading to nociceptor activation, substance P, glutamate, all activating nociceptors, which is the peripheral sensitization leading to acute pain. But that peripheral sensitization facilitates nociceptor transmission, the release of mediators within the dorsal horn, and then leading to central sensitization, NMDA receptor activation, calcium flux, nitrous oxide production, which can lead to neuroplasticity changes within the brain as to how you perceive the pain, which can actually lead to, even in a postoperative situation, if the pain is not controlled, the person can end up with a persistent postoperative or chronic pain. So, preemptive analgesia is the administration of an analgesia before the onset of the noxious stimuli. The goal is to prevent the wind-up, as I talked about. So before we go over the cliff of surgery, this pictorial, and it goes A, B, C, and D, as you can see. So A is a depiction of, in the very beginning, the surgery itself, and you have this nociceptor input from the surgery itself, and then after the surgery, the lower hump is the after surgery. But the patient is experiencing continually this hypersensitivity pain syndrome. Whereas if they get their analgesia after surgery, so the first hump is they've had surgery, then they get analgesia, they get rid of their pain for a little bit, but then they still have the nociceptor input and they still have the hypersensitivity to a large degree. Whereas in C, if they get the analgesia before their surgery, it knocks out the nociceptor input during surgery, but they still have it after surgery. Hypersensitivity is knocked out during surgery, but they still have it to a large degree after surgery. Whereas if they get the analgesia before surgery, that nociceptor activity is knocked out during surgery. And then the A's with the arrows on it are they're getting more analgesia, and this would be their multimodal analgesia that they're getting post-operatively, knocking down the nociceptor input, and their hypersensitivity, in theory, is gone. And so that is the most effective way for analgesia prior to surgery, is not only preemptive, but multimodal post-operatively. So multimodal analgesia is that hitting pain from all different avenues, be it peripherally, spinal cord, as well as central nervous system and the brain. And there's all kinds of different medications that can be used for that. So some people think of preemptive analgesia as kind of like a subset of multimodal analgesia, but in the literature, it can be confused between the two. So you have to be careful when you're reading it, what they're referring to. So the goal of multimodal pain management in general is to improve pain with less side effects by targeting the variety of the chemical and neurophysiological pathways, decreasing post-op pain while decreasing opioid use. That's also the ultimate goal. Sure, we want people to have less pain, but we also want to decrease their opioid use by targeting all the different mechanisms with different kinds of medications. So back to the study that was done here several years ago by Debra Gordon, who was a pain clinical nurse specialist at the time, who's now a bigwig at the University of Washington, Seattle, and is also a bigwig in the American Pain Society. And Sharad Rajpal, who's a bigwig spine surgeon in Boulder, Colorado, as we can see in this picture off the internet, led up this study. And what we did is we had 100 patients who were pre-intervention. So most of those people back in that day, we used PCA pumps. This was done with orthopedic surgery also, and they definitely used PCA pumps. Then 100 patients were post-intervention. So a little bit of history is that Deb Gordon had worked with ortho on joint surgery, mostly knees. I think there were some hips, but it was mostly knee surgery, and had done some work with them on that. And she thought that spinal fusions would be a good next step. So what our intervention was back then was preoperatively in first day surgery, patients received gabapentin 600 milligrams, long-acting oxycodone 10 or 20 milligrams, depending on their age, and acetaminophen 1 gram. Post-operatively, in their post-op orders, they were receiving 600 milligrams 3 times a day of gabapentin, long-acting oxycodone 10 to 20, depending on their age and if they were narcotic naive or not, but usually we just went on age. Now, short-acting oxycodone back then was ordered 5 to 20 milligrams every 3 hours. We shouldn't be doing that now, and I'm going to talk about that more in a moment, but that is what we did back then. And acetaminophen 1 gram TID. All these medications were adjusted for age. If they had any liver dysfunction, it should also be adjusted if they have any renal dysfunction, because gabapentin is renally cleared. Opioids, naive or not, or lack of opioid history. So what we found, we had Deb had a research assistant that collected all the data, which was really great. What we found was significantly less opioid consumption in the intervention group compared to prior to the protocol. So the post group had significantly less opioid consumption than the pre-group. Lower ratings of least pain, less nausea, less drowsiness, less interference with walking. So we did have some functional measures in here also, and less interference with coughing and deep breathing. This, we'll talk a little bit more about this study in a minute, and the pluses and the minuses. This is a paper that was written by the orthopedic surgeons at Thomas Jefferson in Philadelphia. And this is a really nice review paper. This paper was not a rigorous paper. It was not a systematic review, but a really nice overview. And they came up with, when they're talking about multimodal analgesia regimens for pain management after people undergoing spine surgery, they did include the Rajpal paper, and they included these other 3 papers. The reason that I put this up is that this is the author's interpretation of these papers. I did not review all of these and their level of evidence interpretation, but I put this up because you just saw a moment ago about what we used for our intervention, preemptive as well as multimodal postoperatively. These authors each had a different medication regimen for their intervention, and that is throughout all of the literature. We'll talk more about that in a moment. The other thing to note is on ours, they talk about the medications used, but they didn't talk about the fact that we used preemptive as well as postoperative multimodal analgesia. So to be careful with that. The authors did find that these regimens were all effective. So this was a rigorous systematic review looking at postoperative pain after lumbar procedures, and they looked at local anesthesia, intraoperative measures, as well as postoperative measures, preemptive measures, and local anesthesia also, which I do not talk about. And I just want to point out that these authors also found much heterogeneity in what kinds of medications are used preoperatively as well as postoperatively. And this was quite a rigorous review. So for school, a semester or 2 ago, I did a systematic review. I learned a lot doing this on not how to do a systematic review and how you have to ask the questions correctly. And if you're ever interested in learning evidence, a good course for evidence-based medicine is through NAS, and I've learned a lot through that. But at any rate, I wanted to pass along to get back to patient-reported outcomes versus clinician-reported outcomes when it comes to pain post-operatively. I looked at this, and the authors used the visual analog scale or the numeric or the verbal rating scale. And I looked at 9 studies, 6 randomized control trials, all significantly less pain, and 3 retrospective studies. However, once again, interventions totally heterogeneous. They looked at patient-reported outcomes, also looked at some functional status, and health quality measures were rated as patient satisfaction scales. Clinician-reported outcomes included opioid use and adverse events. So opioid use in several of the studies noted significantly less total opioid use in the intervention group. One study, interestingly, didn't measure opioid use, and one study was no different. For adverse events, was also interesting because they looked at blood loss and drain output and bony union, which I don't really, I mean, I care, but I don't really care about that when I'm thinking about pain as much as constipation, dizziness, you know, inability to participate, hypotension, etc. Most of the studies had no difference between control and the intervention groups, which is important. 3 groups did have less nausea in the intervention group. Functional status, only 1 paper looked at functional status being PT, which people with where physical therapy measured the day of ambulation. It was sooner in the intervention group, and the length of stay was less in the intervention group. So moving on from those studies that show there's research that's out there, but it's all very heterogeneous, to the American Pain Society guidelines. for postoperative management of pain. Now, this is general postoperative, not specific to spine surgery. They had 32 recommendations, and Deb Gordon was on this committee. And just a couple of things to point out. They found a strong recommendation, high quality evidence for multimodal pain management in kids as well as adults, and moderate quality evidence for the use of Celebrex and gabapentin. So I included this slide because this is a slide from Sharid, and I wanted to put this in as a physician perspective. And what Sharid's take was on those guidelines from the American Pain Society was, first of all, NSAIDs, that they found strongly recommended and high quality evidence for the use of NSAIDs in patients that is not contraindicated, as well as Celebrex to be used preoperatively, also strongly recommended moderate quality. And then lastly, gabapentin, which you probably all know I'm a believer in, and the dosing ranges is pretty substantial for these pretty substantial range from 600 to 1200 milligrams. And then ketamine also. Of note, they noted that gabapentin use decreases delirium and anxiety, probably because they have less opioids, but you do have to be careful with gabapentin. And some people, they don't tolerate it as well and you need lower doses. And we definitely have been starting 300 to 600, and we don't hardly ever go above that except in rare circumstances. People definitely get more sleepy with 1200. And it has a synergistic effect with opioids as well as COX-2 inhibitors is what these authors found. And we don't have much history with pregabalin here. So back to the Jefferson group's article, they also looked at neuromodulating agents after spine surgery, and again, a lot of heterogeneity, but a lot of positive results and some class 1 evidence for pregabalin as well as gabapentin. And these were all randomized controlled trials. So back to Sharid's thinking about nonsteroidal anti-inflammatories. This is an article from just a couple years ago looking at biochemical animal and human studies. And these authors' conclusions were that NSAIDs appear to be dose-dependent and duration-dependent, and that short-term use of low-dose NSAIDs around the time of spinal fusion is reasonable. And then the Jefferson people also looked at NSAIDs. The ketorolac groups on the bottom and top of this chart did have more or higher rate of non-union. And then the middle two groups had lower pain scores, but they did not address non-union in these. And once again, this is the author's take on this, and this review was not a rigorous review. So maybe I shouldn't be passing it along, but it was a good review article. Well, combination of medications to use for postoperative pain, we've seen all kinds of different medication combinations, so it's really unclear. But if you do use gabapentins, you need to decrease the amount of opioids because they do have a synergistic effect. And I wish I had an answer to what the combination is. And so we'll talk in a second about what I feel is important in our hallway. Lastly, I wanted to bring up that the American Pain Society has an as-needed paper on as-needed orders, PRN orders, that the nurses are deciding how much medication a person should get. Once again, I do not condone the 5 to 20 any longer. We usually start 5 to 10 every 3, maybe 5 to 15. And I think in general, the nurses try to not give as much, but that's not always the case. Luckily, we haven't had any Narcan use in a long time. But we'll talk about multimodal for us in a minute, because we do have experienced nurses, a lot of them, but we also have a lot of very new nursing staff, and this is quite the decision for them to be doing. So preemptive meds are given before spinal fusions. I talked to Shelley yesterday, and they are giving preemptive medications as I described prior. So postoperatively, I'm still a firm believer in gabapentin, as needed oxycodone. I think that they do well. On a few days of long acting, we use morphine now. We don't use OxyContin. That's a bad medicine, and people sell it and stuff like that. Avoid benzodiazepines. It can make people too tired. It's lipophilic. It builds up in their tissues, and then they can have bad side effects from that. So I really try to avoid benzodiazepines. We use muscle relaxants. Ever since Darnell came several years ago, he was using Robaxin, and Robaxin seems to be very helpful. The nurses really like Robaxin, and people don't get as sleepy from Robaxin. And I would schedule that. We schedule the acetaminophen postoperatively also. And if they've had a big fusion, I would schedule the 15 milligrams twice a day of the long-acting morphine, and then they've got the PRNs available. Monitor, monitor, monitor. This takes a lot. This is very time-consuming, adjusting, a lot of tweaking constantly, and talking to the patient on how they're doing. Lastly, it's really difficult when we have patients on different floors because they don't know how we do it and how to take care of our patients as well. So we need answers. We need optimal postoperative pain protocols. We need algorithms. We need pathways. It's a big multidisciplinary effort. This is a great place for like a industrial engineering kind of evaluation where you're looking at the patient and their pain in the center and all the things around that affect it, and to make the system help the patient instead of the patient having to fit into the system. It is a basic patient expectation. So in summary, the goals for multimodal therapy are to improve pain with less side effects by targeting a variety of chemical and neurophysiological pain pathways, decrease their opioid use afterwards. It's a big problem, and if it's not well treated, it can lead to chronic pain. Preemptive and multimodal oral pain management have been proven effective in the spine patient population. There's endless opportunities to help our patients answer questions, give clinicians the guide. We have no idea how long to keep them on this. How should we taper them when they go home? What should their discharge be? And patient expectations seem to have really changed. At least they don't come in anymore thinking that we're going to, they're going to have no pain, most people anyway. It does require reevaluation, constant effectiveness tapering, and titration of the meds. And this is a patient that this is what we're doing this all for. And I would just like to thank everybody again for your attention and for all of your help over the years. That's it.
Well done.
Hey, Andrea.
Well done, Andrea.
Yeah, very good. This is Stan. Sorry about the road noise.
It's okay.
Can you hear me okay?
Yeah, I can hear you.
So you didn't mention in your talk at all, other than PCAs, the use of IV pain medication. How come?
Oh, because it's really not a part of PRN IV pain medications should be minimally used. They can go to oral unless they're actively having emesis. They can go to oral pain medications right away post-op. The IV one should be minimally used, and definitely not PCAs. There's a recent article out of BNI that talks about the evils of PCAs in spine surgery. But even the PRN, I would say minimal. And other floors think that you can't give people oral pain medications until they're tolerating food, but that's not true. They will tolerate it. Does that answer your question?
Well, yeah. So I was just going to make the comment in that that you know, the IV pain medications, their half-life is very short, so they don't last very long. And so patients get just this little few minutes of respite, and then they're back to being in more significant pain.
Right, and that's right. That's the whole goal of the long-acting and the short-acting. The long-acting gives them a good base of pain control, and then the short-acting oxycodone is for the breakthrough pain. And the IV is makes people very nauseated, and is also contributes to urinary retention. And it's very short-lived, and they get in this really bad cycle of this need cycle. And it's not the person, it's how it affects their brain.
Right. Yeah, it's the centralization of pain. But the use of the thing you mentioned about PRN medications, if you have too many of the medications are as needed, then the nurses typically, depending on their seniority, will use them either effectively or ineffectively.
Right. I would try to have everything scheduled that you can. Right.
Everything you can within reason, safely, because is typical. Because of course, you know, an IV pain medication seems more doctory. It seems more medical.
Right.
That if they have an IV pain medication ordered, they often will get it because it has this presence of being more of a procedure, but it has less effect. So a pill is definitely a preferable way to go. They're longer acting. The patients can actually sleep instead of getting a little sleep and then waking up in pain and then getting a little sleep. So that sleep deprivation cycle doesn't play into it as much.
Right.
Did you find anything about topical treatments such as lidocaine, ice, the cooling blanket type thing?
I should have looked again. I know that there has been literature on temperature, heat and ice. My recollection is that ice is effective, but I would have to look at that again. That might actually be in those guidelines from the American Pain Society. I'll have to relook at that again. I know that ortho's really big into ice right now and cooling, so I'll have to look at that again to see if there's any actual evidence.
Andrea, every chief resident, including me, tries to do a study on injecting local anesthetic into the spine muscles before they close, and then abandons it after a while because of ineffectiveness. Some faculty continue it to this day. Any literature on that at all?
There is on local anesthetics, and I don't have it right in front of me, but they didn't find it to be effective.
I agree.
So I can pull that out again.
So that being said, but actually Rajpal's group does intrathecal narcotics intraoperatively, and they've found that patients have very little pain on day 1 and 2, and they're ambulating well, et cetera. The only problem is they get urinary retention on a certain subset, but we already get it, so I don't even know if that would be necessarily a problem for us. So there are other things you can try. There's a whole litany of other potential treatments that people have tried that may or may not have efficacy, but it certainly is worth considering.
Well,
There's a newer liposomal bupivacaine that's supposed to work for longer.
Yeah, Mike Wang's big into that. Clayton's going to learn all about it because that's what Mike Wang uses. But he uses that as ES protocol.
Yeah, I couldn't get it either. It's only approved for cancer surgery.
Yeah, we don't have it.
It's approved now for spine.
Oh, last time I asked for it, they said it's restricted use.
Yeah, they changed that. I'm fairly certain that I don't know if it could be for every procedure, but it may be for lumbar spine or something like that we can still use.
Yeah, we've been able to get it on the pediatric side at least a couple times.
Where's that? Remind me, where's that injected at again? Where does it go?
Just locally in the muscle.
Local in the muscles.
Muscle?
Well, actually, the guidance is actually to target the musculocutaneous nerves as they exit the fascia. So it's actually the mid scapular line posteriorly. It's not directly in the wound. So there's different direction on where to inject it than what we typically do in order to try and give it more of a regional effect rather than a local effect.
Wang was saying for MIS cases, they would just inject it in the screw trajectory.
Right. That's right. He injects it into the screw, like the screw hole before he puts the screw in, right? I think.
Yeah, through the muscle and fascia.
Yeah. Yeah. I would have to look into that more.
I think that the bottom line about this is that you're trying to come up with other ways besides narcotics to treat the pain. As many of my patients say, especially the elderly patients, they say it doesn't really help your pain; it just makes your mind fuzzy.
Right.
Precisely. And so one of the other important modalities is actually to tell your patients that it's going to hurt, because they kind of sometimes have this. Their thought process is we have some amazing tools that we can use to make it so they go through surgery with zero pain, and that really isn't a helpful mindset to go into the operation with.
Right.
And I also tell them that we're not trying to treat them down to zero pain. We're trying to treat them to getting functional.
Right, and we started. Yeah, we started this for posterior cervical fusions and lumbar fusions. It's really, it's not meant for ACDFs or microdisc and things like that. And you have to be careful because some of these studies, they're looking at surgeries that shouldn't have much pain anyway, like an ACDF. It's like, so right. These protocols were not meant for ACDFs or microdiscs. So bigger surgeries. All right, any other questions? All right, great. Thank you.
Thank you.